Today, on Trips and Health, a closer look at the 21st Century Cures Act. The 21st Century Cures Act is legislation that is currently making its way through Congress. Having already received approval in the House, it is now under consideration in the Senate. Despite major support in Congress, outside of Congress, a broad range of critics have pointed out significant concerns with many of the legislation's provisions. Those concerns may be grouped into three specific areas: the safety, efficacy, and sustainability of medical technology, medical ethics, and drug prices. We'll begin with the implications of this legislation for medical technology. The safety and efficacy of medical devices, like drugs, must be approved by the FDA. Section 2222 of the 21st Century Cures Act proposes significant changes on this oversight. If the law were approved in its current form, medical devices could be approved based solely on uncontrolled case studies and journal articles alone. This would mark a radical break from the gold standard of randomized controlled studies that the FDA has long used to ensure efficacy and safety of medical devices. Of perhaps even greater concern, under Section 2221, modifications to approved devices could now be verified by third parties contracted and paid by the device maker itself to certify manufacturers' quality system. With certification of a quality system, device makers would then be free to introduce new modifications without FDA approval. In other words, the manufacturer would be authorized to determine for itself whether each device remains safe and effective following important changes to the device. As currently proposed, the 21st Century Cures Act would also lower standards for the FDA's determination of safety and efficacy in antimicrobials through a program known as the Antibiotic Development to Advance Patient Treatment Act, also known as the ADAPT Act. As currently written, the ADAPT Act would expand the use of surrogate endpoints for determination of efficacy and allow for the use of significantly smaller trials. The ADAPT Act could even allow for FDA approval of antimicrobials based on preclinical data, another radical departure from current standards. Support for the ADAPT Act leverages the momentum behind the crisis of antimicrobial resistance that we're now facing. But is this momentum being channeled in the right direction, or even simply the ideal direction? Is the expanded use of surrogates simply shifting the goalpost we use to define success? And why the rush to accelerate FDA approval if we've just approved new rules for compassionate use that allow those patients in desperate need to access drugs before their approval anyway? Furthermore, it's not as if the Congress, for better or worse, hasn't already acted to address the antimicrobial resistance phenomenon. With the Generate Antibiotic Incentives Now Act, also known as the GAIN Act, Congress mandated to the FDA that they provide 5 years of additional regulatory exclusivity for any new antibiotic or antifungal approved. That's to say, the FDA would provide 5 years of additional monopoly, independent of patent status and on top of other exclusivities already granted by the FDA, meaning that new antibiotics or antifungals, regardless of their patent status, could be granted monopolies of 10 years, 12 years, or even 17 years, and that doesn't even include further exclusivities that they may be eligible for. In another provision with significant implications for antimicrobials, Section 2123 of the bill would encourage the overuse of antibiotics by giving hospitals a financial bonus each time these new drugs are prescribed. Such a policy would only accelerate the rise of antibiotic resistance in new drugs and represent the exact kind of distorted incentives that gave rise in the first place to the antibiotic resistance to old drugs that we're now trying to develop legislation to overcome. Our next area for concern involves the impact of the 21st Century Cures Act on medical ethics. In particular, the Act would exacerbate a troubling lack of transparency in the ways that industry may influence medical schools and continuing medical education. Section 3041 would significantly undermine the Physician Payment Sunshine Act, which was designed to make public potential industry influence by requiring industry to report their funding of continuing medical education training. By requiring greater transparency about payments made to academics lecturing at continuing medical education training, the Physician Payment Sunshine Act had sought to limit the potentially distorting effects of industry funding. After all, when teachers are the ones paying to educate students, we should at least be suspicious and take steps to ensure that conflicts of interest within the health sector don't damage the public health of society. The same suspicion applies to industry contributions to textbooks or provisions of textbooks to medical schools or for continuing medical education. At the very least, this influence should be reported. Another disturbing provision of the 21st Century Cures Act would eliminate informed consent for trials in which the proposed clinical testing poses no more than minimal risk, but the provision leaves unclear just who would determine the definition of minimal risk. In fact, a recent piece in the New England Journal of Medicine declared this to be, quote, a major departure from current human subject protections. Finally, the last concern that we would like to highlight involves implications of the 21st Century Cures Act on drug prices. Under Section 2151, the Act proposes a 6-month additional monopoly for all exclusivities granted by the FDA if an approved drug also has an orphan designation. Without going into too many specifics about orphan drugs, suffice it to say that between 2011 and 2013, nearly 50% of all drugs approved by the FDA held an orphan designation. Furthermore, an orphan designation already gives an applicant for a drug 7 years of monopoly for a given indication. By systematically granting a 6-month extension to originator drugs, this legislation would delay the entry of generics and ultimately cost the U.S. consumer and taxpayer tens of billions of dollars per year. Why would the U.S. government introduce legislation that leads to tens of billions of dollars of unnecessary spending per year? This might be a good launching point to review the rules of skepticism that guide us here at Tripson Health. Rule number 1. The question cui bono, or who benefits, is a good starting point, but it need not predetermine our conclusion. Number 2. Though all laws need not prioritize private over public gain, any law could, and many, if not most, do. And third, we should never discount that laws may always achieve the opposite of their label. This rule applies to the optimistically, and some may say euphemistically labeled, 21st Century Cures Act. And finally, our rule for pharma-related skepticism acknowledges that laws could theoretically go against farmers' wishes, but in practice rarely do. Which brings us to our conclusion. The FDA has long operated according to the precautionary principle, namely, that the burden of proof is to demonstrate that no harm is done by a given piece of medical technology, whether a device or drug. Perhaps this principle should also be applied to laws supported by the industry. That's to say, the burden of proof should be to demonstrate that this law does not prioritize private gain over public interest. While one might consider that a cynical attitude, I prefer to call it informed skepticism. And informing you well enough to reach your own conclusions about this law was, after all, the point of this video. Thanks for your time.